صباح الخير. كويس بادئين بدري. First of all, we very happy to have أستاذ الأجيال أستاذنا الدكتور ماهر. سعداء بوجود حضرتك. تشريف أستاذنا الدكتور هاني موافي. احنا يعني فخورين بوجود حضرتك. دكتور محمد الشرقاوي. يعني هيخلي الموضوع أصعب علينا. لأن لما نيجي نتكلم في العلم هيبقى شوية الموضوع أصعب. أنا عارف إن التوبيك هيخلي دكتور وليد ودكتور عمر يضايقوا مني شوية، بس احنا we try to make it easy and simple to understand what are going to deal with. The fibula, should I fix or not? We all that Pillon fracture is a disaster from the beginning. Trying to deal with proper or not trying to deal with proper, you may have a disaster at the end. So we are trying to minimize the amount of disaster. This is our situation daily in our clinic to see such horrible infected wound. So it's not only a bone trauma, it's a bone and soft tissue. So when we are trying to deal with, you have to put in your consideration, it's not only to prepare a good articular surface, but to respect also the soft tissue. There is no clear protocol suggest the sequence and method of fixation. However, 70 years ago, Rudy and Algover, they put the protocol to restore the fibula. Then you can be able to restore the articular surface. Then you can put a graft to support your articular surface. Then put a medial buttress plate. Why the fibula matter us? Because it is the lateral support. And it's responsible for the mortise configuration. The syndesmosis stability is very critical for the length and the width. The alignment facilitates the reduction of articular surface. And that's much easier when you restore the fibula. You can see a very good looking for the articular surface. And many articles supported that. But the risk that you have additional surgical dissection with soft tissue risk. And the one complication for an already damaged soft tissue. You can achieve a good reduction without reducing the fibula. So you don't have always to do that, and you still have a new plate for the lateral side for subcutaneous in a very soft skin. The new techniques right now, which available that could support with a locked plate, give you 2 rows of screws, would give you a much more support for the reduction with a multiple direction and multiple fixation. Fibula fixation may not be necessary in the treatment of tibial Pillon fracture, and primary stability could be achieved with tibial fixation alone. Many articles discussed that, and they compared. And the other side, there are many articles, cadaveric studies also, said that no way you have to reduce the fibula in the proper position. And they found many pitfalls after not doing the fibula in the corrected position. So this put us under stress. We plan to study this question. Is it really necessary to put a plate in the fibula and reduce it at the beginning, or you can achieve it by another way? We did an RCT aiming to know how much the ankle will be aligned and how could we restore the fibular length, see the outcome and the bone union. Our hypothesis is that the fibula fracture may not need to be fixed in all cases of Pillon fracture if you could achieve a Pillon tibial part fixed and reduced alone. 2 years for an RCT, 54 patients. At the end, we found that there is no significant difference between 2 groups regarding time of union. All unite. And this is against some articles. Infection, non-union, post-traumatic arthritis, all are the same. There is no difference. However, we found that functional score is much better with the fibula group. If you fix the fibula, you will have a better outcome. Not fixing the fibula will lead to valgus ankle. However, the effort you are going to do, still you may have a valgus ankle. It may not affect the function at the beginning, but come after 10 years, you may have a big troubles. Why it runs so fast? هو الجهاز بيجري لوحده. This is how to restore. You can restore the anatomical part and you can fix with the bridging plates, not fixing the fibula, have a good relation to the fibular length with the syndesmosis reduced, but you can find at the end that it's a valgus. Your eyes have to understand that this is a valgus in relation to the tibia. You may have a valgus and you can't understand that by measuring the anatomical distal tibial ankle. So evidence of fibular fixation in Pillon fracture is still limited and conflicting. Maybe we are the first RCT to do such comparison, but still we need more sample size. Fibular fixation required more surgical approaches and longer operative time. But there is no difference in the time for union. You can achieve better outcome after fixing the fibula. So put it in your first consideration to avoid also the valgus deformity, but still you have to select the cases. If I want to do it proper, you have to assess the soft tissue at the beginning because you may ignore the fibula if you have a bad soft tissue at the end. Also, evaluate the pattern of the fibula. So when to say I could avoid the fibular fixation, if you have a good relationship between the fibula and syndesmosis. So you can take a look at the CT and you can see the relation between the fibula and the anterior posterior part of the tibial part of the syndesmosis. If you have this good relationship, you can avoid fixing the fibula. If the syndesmosis is disrupted, it's a must to go for the fibula. But still, if it's not displaced with a fragile soft tissue, you can ignore it. You can take your decision after spanning external fixator, because if you span the external fixator and you could see that the fibula reduced at its position with a good relation to the tibial component, so you could avoid fixing it. So fibular fixation in Pillon fracture, it helped to restore the mortise and the syndesmosis, but it may affect the soft tissue. Staging for the fixation is much better. Decision could be guided by the fracture pattern. So every Pillon had its selected fixation. Not all Pillons have the same concept. Always balance between the benefits you are going to have and risk you are going to put the patient at. Thank you.